Can we go back to the first slide? Or, sorry. That's sort of halfway through the talk. I can plug my computer in. That's about the third slide, I think. Oh, I know. Can I use my own computer?
Which port? Do one thing.
And some different ports here.
First, you have to like put it out. That's fine. Just Vijay. Yeah.
I think while Bill is setting up his laptop,
You can have HDMI as well.
Yeah, of course.
a little more about Bill. He is actually a very prolific researcher, and if you go back in pathophysiology of the glaucoma genesis, the relationship between cross lamina fibrosa actually is his work, and which has been there now picked up by many other people. I think it's ready. So, Bill, thank you. Over to you.
Surinder, thank you very much for your kind introduction, and thank you for inviting me to speak here in India. It's such a lovely country, and I really enjoy coming to India. What you're seeing here is the very first human XEN. Well, we didn't call it XEN in those days. It was a cross-linked gelatin stent that we implanted back in 2007. And that followed about 10 years animal and design research work. And I just want to thank my collaborators, the main person being Professor Dao Yu, who was the brains and the engineer and the worker behind most of this work. And also to disclose the fact that I am one of the inventors of the XEN, so I do have a bias, you might say. So the original idea for microfistula or cross-linked gelatin surgery was to create a stent. So, for example, trabeculectomy is an operation in which you basically cut a channel into the eye, and it causes a lot of surgical trauma. The original idea that we had back in 1996 was to inject a channel rather than cut a channel, and so avoid most of the trauma associated with surgery in the likes of trabeculectomy. We wanted to inject a stent made out of a biologically compatible material, and cross-linked gelatin was the material that Professor Yu chose, and spent quite some years refining the proportions in terms of cross-linking and drying, and making it a material that was hard or rigid to start with, and then when it becomes moist, it goes soft and floppy like a vessel. So it becomes a soft vessel. So for example, with the glaucoma drainage devices, they're always rigid to some extent. So every time you blink your eye or rub your eye, you're going to induce a little bit of trauma by having that semi-rigid structure in the eye. Whereas we wanted something that would be flexible. And the other thing was to have an operation where we didn't have to cut the conjunctiva, but we could inject the stent ab interno, so across the anterior chamber, so avoid any conjunctival wound. So this is from our original patent, the US patent from 1997. This was some of the early design work where we initially started with beef collagen, lots of work initially refining the rigidity and mechanical characteristics, and then about 400 rabbit experiments and quite a few monkey experiments to look at the longevity and the effectiveness of the stent. The stent was injected through sclera, obviously through the trabecular meshwork, into the subconjunctival space, And then in those animal experiments, we could look at the histology and check how much inflammatory reaction we were getting. And you'll see here from one of the rabbits that there's very little inflammatory reaction that was induced by the gelatin stent. So there was quite a long story to do with the commercialization and attracting a commercial partner to make a version that could be used in patients. So it's one thing having all the laboratory kit for an animal, but then when you want to use something on patients, it has to be sterile and also usable by the surgeon. So we began the first human trials back in 2007, and over the following 3 years, we modified the insertion device, and I'll show you some different examples of those. We also modified the gonioscopy and the way in which we hold the eye. So I'll just show you, if you have an eyeball here, like my fist, and you inject a stent or something into it, and you're pushing on the eye, just your force will tend to want to make the eye rotate. So then the area of interest, for example, the limbal region on the other side, goes out of view. So you need some way of fixating the eye which doesn't distort the eye too much. So this is pretty much where we ended up at in about 2010, towards the end of the first phase 1 and phase 2 trials. There's a special high refractive index gonio lens. We've made a special speculum with a little eye ring, or semi-eye ring, which you can stitch the eye to. And so as you go through and force the needle through the meshwork and sclera, there's no noticeable counter-rotation of the eye. And also it gives you a spare hand, and you can see the injection needle there. Now it's being withdrawn, and the stent is being delivered into the subconjunctival space. So that's a pretty typical operation. There's a high degree of control where you can see where you're going. Now this is some examples of the insertion device that we used along those 3 years. This one here is the original box. It was a bit like a phaco machine set up with tiny motors that drove the plungers that pushed the stent out. And then it became more and more refined until finally the most recent incarnation is a mechanical handheld system. So we did about 25 patients over those 3 to 4 years, and what we found was that the bleb that was formed was in many ways very much like a trabeculectomy bleb. It could still become encysted. There was a high need for needling with 5-fluorouracil, for example. We also found out quickly that you needed to have healthy conjunctiva for the stent to work. So if you tried to put it into scarred conjunctiva, it didn't work, which was not surprising in retrospect. Also, the bleb tended to be more posterior because the stent itself is 6 millimetres long, so it's delivering the aqueous humour to a position about 4 millimetres behind the limbus. So the bleb tended to be posterior. It did mean that we were able to put some of the stents infranasal. So with the trabeculectomy, we avoid doing inferior trabeculectomies because of the risks of infection. But in some of these patients, we did the stents infranasally, and touch wood, we didn't have any problems. So this is the long-term results. We published this data in Ophthalmology last year, and you'll see we followed patients out to 6 and 7 years, and you'll see that the average preoperative pressure was about 25, and that dropped down to the mid to low teens and stayed fairly stable over the following 6 years. But we did have I should have put in the Kaplan-Meier survival curve. So we did have a failure rate of about 1/3 to 1/2 over the 6 to 7 years. So if you like, the 50% survival is about 6 to 7 years. The other thing that is worth noting is that the numbers of drops that were used before the XEN was about, on average, 3 to 4, and that fell down to between 0 and 1 straight after the XEN. And you'll see the high rate of 5FU injections in the first year or so, which also tended to fade off. so that by about 4 years, not many patients were requiring any further injections. So that was with, I better go back actually, that was with the original version of the microfistula, which we'd started making in the laboratory. It had an external diameter of 220 microns and an internal diameter of 120 microns. Now the commercial version, which was released about 3 to 4 years ago in Europe, has an internal diameter of 45 microns only and an external diameter of 90 microns. And the decision for that was made by the American advisory board. We were not involved in that. Also, there was a decision made to change the collagen to pig or porcine collagen because of fears to do with the mad cow disease and prions. Now, we've had the new version of the XEN, so what's called the XEN 45, in Australia for about 2 years. And in our department, we've set up a database system to track the results of those. And we've just had our first pass look at the data. So this graph, it's accurate, but I can't, there's a few things that I can't show you simply because we haven't fully analysed the data. So this is following out to 2 years, although most of the patients, about 144, have only gone to 12 months. But you will see a reasonable effectiveness in terms of pressure reduction, but note that the average preoperative pressure here is only about 21, 22 on average. So they're not as severe as the earlier patients. The earlier patients had all had failed trabeculectomies as part of their inclusion criterion, whereas these patients have not. And you'll see the handheld system now that we're using routinely. So just a couple of pictures of patients. It is useful in some difficult situations. For example, this patient had retinal detachment, only eye, very high scleral buccal, and you can see in the superior conjunctiva it's really made any sort of drainage surgery in that region impossible because of the very high buccal. But in that eye I was able to put an infranasal XEN in, which is still working a year later. Now this is comparing two techniques. You'll see our technique on the right-hand side and the technique that's currently promoted by Allergan on the left, where they promote the use of a hook to hold the eye, but it means you've then got both hands occupied. And if you like, just have a look at the sort of relative distortion, if you like, that you get. I think every surgeon has their own preference for their own technique and their own biases. My own bias is to use the technique on the right because whilst you have to put 3 stitches in the eye, there's a lot less distortion and there's more control in terms of using a gonio lens and having a free hand. Sometimes one needs to manipulate the conjunctiva in this area to make sure that the needle doesn't penetrate through as well while you're doing the surgery. So ideally we want to have the XEN going through the trabecular meshwork, that's the ideal position, and we also want to have about 1.5 to 2 millimetres in the anterior chamber, probably 1 to 1.5, about a 3 millimetre run through the sclera, perhaps 2 millimetres in the subconjunctival space, and on anterior segment OCT, ideally we want a straight sort of pass through the sclera rather than this wiggly sort of version that I've pinched off the internet. So I'm finishing. I realise I've gone a little bit over time. There's some simple ideas to try and improve the success rate. I do think that getting good control of the eye, having better fixation of the eye is quite important. I think our technique using the 3 stitches could be improved. It's a hassle to put those stitches in, but it's not a huge problem, but there must be a better way. If we could avoid viscoelastic, so at the moment we have to make a 1.5 or 1.2 millimetre incision to get the device in the eye. Initially we did not have to do that for various design reasons, and my thoughts are that some of the patients who did not have viscoelastics have actually done better. So There are some design improvements that could be made to the injection system. Also, if we could improve the gonioscopy so that we can more easily see where we're going, a bit like driving at night with the headlights, you do really want to see where you're going with surgery. And there's a few other points there that I won't go into. And just the comparison with trabeculectomy, it's pretty much equivalent in terms of the 2 to 3 year follow-up data, and our 6 to 7 year data is roughly equivalent to data that's come out of Moorfields looking at their trabeculectomy results. So on balance it seems roughly equivalent to trabeculectomy, but in saying that, there's probably more attention required to attend to the blebs. I suspect there's more 5FU injections that are needed with the XEN. So I'm going to finish there. And lastly, I just wanted to say and invite you all to come to several meetings in Australia, if you fancy coming to Australia. We have RANZCO this year in Brisbane, I think it is, and also the World Ophthalmology Conference in Melbourne in 2022. But thank you very much.
Excuse me, can I have a questions, please?
Yes.
First thing, why did you change the internal diameter from 120 to 45? Number one.
So I'll answer your questions in sequence, if that's right.
Okay.
That's a very good question. I've asked that question myself. That was a decision made by the American Medical Advisory Panel. Are there any Americans here in the audience? No, so I can say what I think, can't I? As far as they're concerned, we're a bunch of kangaroos who don't know a whole lot of stuff, I think. So they were worried about hypotony, and having a larger diameter stent made them concerned, even though in our original trials we had no occurrence or risk of hypotony. And in fact, there seems to be more hypotony with the 45/90 version now. So that's a very good question. We had no part of that decision, unfortunately.
Second question is, what is the risk of getting this 45 bore gen getting blocked with a little bit of inflammation? Because if there is inflammation, the aqueous is getting more turbid,
yes,
and it is likely to get closed, yes, sooner. So if there is no hypotony with 120 microns bore, why should you change it to 45? Yeah,
so in practice, I agree there's a concern there, and I would prefer to use the 220/120 micron stent myself if it was available to choose from. In practice though, with the 45 micron, I've used a number in uveitic patients. So far I haven't seen any block from inflammatory material. Now the numbers I've done have been relatively low, so it could still happen, that's for sure. Now I was also worried about pseudo-exfoliative material, because we have a lot of that in Australia. You probably have the same here. I was concerned that perhaps pseudo-exfoliative material might block the stent as well, and I haven't seen that happen yet. I have seen one patient with unusual white material blocking the stent, and I'm yet to find out what that is, and that patient I then had to do a trabeculectomy on, and they've done okay. But that's one out of about 200 to 300 in the last 2 years who's had a blockage. Now I have had patients where the stent's gone in too far and it's been blocked by iris, but I would put that down to bad surgical technique, so I'm blaming myself for that. And there are issues with one point I put in the end of the talk is you don't have as much control over the axial positioning of the stent as you really should have. And that's one of the sort of issues in the learning curve of doing the XEN, is trying to gain control over that. And that's definitely an area that could be improved in terms of the introducer. So in terms of things blocking the stent that are not iris, for example, it's pretty rare. The main blockage of the stent is actually fibrosis in the bleb, and that's where there's such a high need for 5FU. Sorry, that's a very long-winded answer to your question. Yeah.
And there are reports there is more incidence of blebitis and more incidence of endophthalmitis with gene implant. And what is the incidence of complications in your case?
So in my case, I've had no endophthalmitis. I have seen two cases of endophthalmitis done by other surgeons. In both those cases, the stent had perforated through the conjunctiva. I think one was at the time of surgery and one was later. Now, I've had 3 cases where the stent has perforated through the conjunctiva. And in I think you have to treat them urgently and repair the conjunctival breach quite quickly. I think the problem with the XEN is that if it pokes through, then the bacteria have a direct route straight into the eye, and that's not modulated by any fibrous tissue or immune elements within a bleb structure. And I think that's possibly why the incidence of endophthalmitis has been perhaps more common. But I think a lot of that boils down to good bleb management. I haven't seen it in my own patients.
And what is the longest follow-up period for you, sir?
For me, it's now 10 years. So the patient that you saw at the very beginning, 2007, she died of heart disease 2 or 3 years later. Most of the other patients were done in 2009, 2010, so they're now followed out for 10 years. And half of them are doing very, very well.
Thank you. Thank you very much.
Thanks.
Thank you, Dr. Milind Morgan, for the wonderful talk and to give us an insight about the XEN. I would request all of you to please come on stage, the previous IC instructors, and Dr. Morgan to please come.